Yes, I just did. Thank you so much, Sunita and Sandy and everyone else. I actually want to open by thanking Ethnic Media Service for these briefings to get accurate information out to our diverse communities. I think it's all kinds of news is going on out there, and they're not always delivered appropriately, accurately, particularly in ethnic languages. And I think this is just incredibly valuable what you're doing. And I have to say, I'm so excited today because I can't think of anything better than doing this in multiple languages. I mean, that is what all of our system, we should insist on all of our system doing this all the time. If we really mean when we say about having an inclusive, equitable country. So kudos to you all. And I'm just fascinated by the tech of what's going on here. Now, I haven't been back. I've been away for 5 weeks from this briefing, and it feels like a lifetime. This is how COVID pandemic time is working out for me. But it allows me to look back at what happened 5 weeks ago and sort of give you an update. And so as of August 13th, yesterday, there were 21 million people, or nearly 21 million people, who have COVID-19 across the country, the world, and about 750,000 deaths. These are just staggering number just to think about. In the United States, we have 5.3 million infections and more than 167,000 deaths. There are actually papers that argue that we're already over 200,000 deaths because of the way we're misclassifying COVID-related deaths. When I last gave this briefing, I was actually very shocked and dismayed that the number of infections in the United States had increased by 50% over the preceding 3 weeks. Well, in the 5 weeks since that briefing, the number of infections in the United States has gone from 3.1 million to 5.3 million, for an increase of 66%. Okay, in the first 14 weeks of the pandemic, when we thought things were going really badly, there were 2 million infections. In the last 8 weeks, we have 3.3 million infections. California, Florida, and Texas have all passed the 500,000 case threshold. California is almost at 600,000. The only slight bit of optimism is that the trend in the number of new cases have been decreasing in quite a few of the states. However, to balance that optimism, as we would expect, because deaths usually lag behind new cases, the trend line for the last 2 weeks showed an 11.6% increase in deaths nationally from COVID. A report that just came out this morning from the CDC looked at 79 counties in the United States identified as hotspots for the pandemic in the first 2 weeks of June. The first thing about that report that was shocking is there were actually 205 counties that were hotspots in 33 states, covering 93 million Americans. However, only 79 counties, or 39% of them, had adequate race data. In other words, they couldn't analyze the other ones for racial and ethnic disparities. I think that's an indictment of our government, our public health, and our healthcare system, that we can't even collect data on our people. 76 of the 79 counties that actually had adequate race data, 76 of those counties had racial ethnic disparities. 59 of them reporting disparities for Latinx, 22 for Black Americans, 19 for Pacific Islanders, 4 for Asian Americans, and 3 for Indigenous people. So the disparities issues that we've seen early on in the pandemic has persisted. No matter which state, it moves from, New York, California, now it's in Mississippi, Alabama, it still persists throughout whichever states we're talking about. A report just came out from the CDC.
Dr. Nguyen, we have a request. What you're saying is so important. Can you just slow your delivery down a little bit? Okay.
A report just came out from the CDC this week regarding mental health issues during the COVID pandemic. Again, I'm giving you numbers, and there are a lot of numbers, but they're just shocking numbers. During June, 40% of the 5,000 or so respondents in the survey reported mental health issues, including 11% who had considered suicide in the last 30 days. 11%, 1 out of 10 people. For comparison purposes, the usual rate of having suicidal thoughts in the United States in the last year, 12 months, is about 4%. Young adults in particular had much higher rates than older adults. 75% of those aged 18 to 24 reported some kind of mental health issues. And a staggering 25%, 1 out of 4, report having thoughts about suicide in the preceding 30 days. And no surprise to us, Black and Latinx reported higher rates of mental distress compared to whites, with twice as many Black and Latinx people reporting suicidal thoughts compared to whites. Other things from that survey that I thought was incredibly important to share with you: almost 1 out of 3 Americans who had a less than high school education reported suicidal thoughts. And 22% of essential workers did too. Although when they did a multivariate analysis, mental health distress was not significantly worse among them compared to other workers. A major new finding that I thought from this study was that unpaid caregivers also had a suicidal thought rate of 30%. And they were 3 times more likely to have suicidal thoughts or start using substances to cope compared to those who are not unpaid caregivers. So from a disparities perspective, what this says to me is that not only are racial and ethnic minority people dying more from COVID, getting more COVID, dying more from COVID, their family caregivers are actually suffering more as well. And as distressing as this study on mental distress is, I think it's going to get worse. There are reports that up to 30 million Americans, more Americans, will become housing insecure due to the economic impact. And I'm now viewing the COVID-19 pandemic as being more than about a single disease caused by a single virus. We are witnessing the beginning of an associated epidemics of mental illness, bad outcomes in many other diseases, and a terrible, terrible change in the social determinants of health, such as income, employment, and housing. The metaphor that I'm using is that the pandemic is a meteor drop on the earth, and in addition to the direct destruction underneath it, we are also seeing the ripples of shock waves in all healthcare system, and just generally society. I'll finish with a little bit about children. There's been some back and forth about children in COVID, an important topic as we consider what to do with schools. The number of infections among children have been rising. So as of July 30th, there were nearly 340,000 children who had COVID, with an infection rate of about 447 per 100,000. A third of those cases were reported just in the last 2 weeks of July. The states with the worst infection rate among children were Arizona, with almost 1,100 cases per 100,000. South Carolina had 959. Louisiana had 859. Mississippi with almost 800, and Florida with 711. Just FYI, the American Academy of Pediatrics had issued recommendation that children aged 2 and older should wear face covering when they cannot socially distance. There's been some debate about whether or not a 3-year-old can actually put a mask on and not put a mask on and keep it on. There's been some sort of anecdotal evidence that they can. But the American Academy of Pediatrics says that if you're going to let kids back in school, they have to wear a mask.
I'd like to next bring on Dr. Nirav Shah of Stanford. Dr. Shah, when I heard you at a previous briefing in May, you said that the US and the world at large was being very optimistic about having a vaccine and drug therapy by the end of this year. And I wonder if anything has changed in the few months since I last heard you speak.
Well, I'm not going to be getting on a flight to Russia and rolling up my sleeve for their vaccine. So perhaps technically I'm wrong. There is an approved vaccine. The reality is that any vaccine that's been actually tested using normal standards is going to have side effects, is going to be hard to take, and the efficacy is not going to be what we ultimately will have for efficacy 6 months, 9 months down the line. When you first release a vaccine, the vaccines are full of side effects. You can see in the small studies of a few dozen patients that have been done, they've all been done in healthy young volunteers. Healthy young volunteers require 2 doses of the Moderna vaccine and have a lot of side effects. Now, when they tested among 30,000 people, I imagine there will be many more side effects in people who are not young and healthy. And those are the people we want to protect first. So as much as if it's a perfect world and everything happens right and we have a vaccine released that we actually trust and believe in the Western world or in the Eastern world, in China, by January, it won't be ready for prime time. We won't have enough doses until at least 6 months later under any scenario. And if you ask people that question, will it be ready? Will it lead to herd immunity and all of the things that we really need from a vaccine? I think they will agree. When you ask the question, will we have a vaccine? People will say yes. You're muted, Sunita.
Please continue with your presentation, Dr. Shah.
Thank you. If you could please project the slides, Jessica. If you're unable to share, Jessica, I'm happy to. So I am, by way of disclosures, I will be talking about two places where I advise. COVIDactnow.org has some data that I will show, and I'll also talk about data from Kinsa Health, which is a private company. Other than that, I have no potential conflicts of interest, and I am happy to share if you're having problems.
Jessica, can you allow Dr. Shah to share slides? Okay.
So let me get into some of the content regardless. You know, we have been talking about how do we control this virus, and there are differences of opinion. Do we go on one end with total containment and eventual elimination, like New Zealand, like Taiwan, and like some other countries? Or do we go toward herd immunity, like Sweden and Brazil, which allows the... Yes?
I'm going to let you share.
Thank you.
We have a glitch.
You've disabled attendee screen sharing. I'm sorry, I can't share. So the opportunities between one end of the spectrum, which is not allowing, which is letting the virus run rampant and trying to get everyone to herd immunity. And next slide, please. And so we've seen very successful strategies, including opening and keeping schools open in Asian countries who've tried successfully with containment. And so right now there's a false choice between lives and livelihoods. Do we save lives or do we keep people working? It's a false choice. You can have both. And we know what that answer is. And it isn't herd immunity, which is a nice clean term for saying we're not going to try to fix anything. We're going to just let everything go on as normal and ignore the science. Next slide, please. So what do we need to actually reopen safely? This is not rocket science. You could make this slide yourself. We need an early warning system. We need broad and efficient testing. We need effective quarantine, treatment, data, and vaccines. Let's go to the next slide. So what is an early warning system? This is an example of an early warning system. 1.5 million smart thermometers in America that at the first sign of illness, you take your temperature at home, it creates a signal that is captured on the internet and tells you where there's unexpected fever hotspots in the country. This early warning system gives an 18-day early warning, a leading indicator, early warning of where COVID is in the community before you wait for someone to get sick enough, feel bad enough to get tested. Tests, by the way, take 3, 5, 7, 10 days to come back now. Show up at a healthcare system, get admitted to the hospital, and die. Right now, we're relying on lagging indicators. People dying from COVID, people waiting